Well, good morning. I see that we haven't exhausted everyone yet. And thank you for coming to the Mansfield Conference again for our final day. And the first talk of the day will, as you all know from the title, will be by McArdle. And I'm going to introduce Mark Hansen. Mark Hansen is going to be running this particular session. And he's a colleague in the College of Liberal Arts. He's our resident expert on medical ethics, and so anytime we do something on medical ethics at the Mansfield Center, Mark is the guy that we turn to. He's a smart guy, an excellent instructor, and a good guy to work with, so I'll just turn it over to Mark.
Okay, thank you, Dane. Kind introduction. And I just want to add my word of thanks also to everybody here for attending the conference both today and other sessions as well. It's been a great conference and a real pleasure and honor to be affiliated with it. And so want to add my word of thanks to our speakers and for their endurance and these multiple sessions. I was part of the organizing group for brainstorming about this particular conference, and we were casting about for issues that would help sort of lay bare in an interesting way some of the tensions at the heart of our event here, which is this tension between individuals and communities, primarily in relationship to healthcare. And it didn't take us long to stumble upon what really is perhaps one of the most interesting and complex and timely case studies in terms of this particular theme, and that was the issue of obesity. And I had thought of stepping up here with a big gulp in my hand as to kind of make the point that has been in the news recently about the way in which even our choices in beverages and and beverage size are now at the heart of political battles about that are really part of the heart of our history in Western political philosophy, the relationship of government authority to individual liberties, and what extent should government have in terms of restricting individual liberties. The issue is also about, obviously, personal responsibility for making healthcare choices that benefit, not only themselves, but the broader community, if people are indeed increasingly part of the same pool of the same healthcare system. Is obesity simply a product of free choice? What are the roles and responsibilities of community and of government in relationship to obesity? And how do these questions relate to the broader questions of, and shed light on our discussion about the future of healthcare in America? Our presenter today has already appeared a couple of times before the conference, and we thank her and Jim for their perseverance and willingness to serve in really what's been a nice ongoing conversation on multiple panels about our conference theme. But I know there are some of you who are joining the conference today for the first time, so I will once again introduce our featured speaker and panelists. McArdle is special correspondent for Newsweek and the Daily Beast, Schwartz Fellow at the New American Foundation, and former senior editor at the Atlantic Monthly, also writer for The Economist. She's written a number of pieces on the question of obesity that have generated a great deal of public discussion, so we're very fortunate to have her here today. Following her presentation, we'll be joined by two panelists. One of the things I think is great about this conference is that we're adding to this national conversation perspectives from on the ground here locally in our own community. And so we're privileged to have with us Heather Sorrow, who is a public health nutritionist at the Missoula City County Health Department. She's a registered dietitian with degrees in engineering and a master's in nutrition from Framingham State College. And I think I'll let her say a little bit more about some of her work that she does locally in the community. Also, familiar to many of you now, Jim Marone. He is professor of political science and urban studies at Brown University and the author of 8 books, including The Heart of Power, Health and Politics in the Oval Office from Roosevelt to Bush, and Hellfire Nation, The Politics of Sin in American History. But to get us started today, please join me in welcoming McArdle.
Hi, am I on? Yes, I am. I can hear myself. Better get away from the mic. So the subject of the talk, as you can see, is on obesity and America's healthcare cost crisis. So I'm going to start off by showing you a graph that probably many of you have seen some variant of. But this is what we are talking about most often when we are talking about obesity. We are talking about the scary growth of what's happening to Medicare, and presumably what may also happen to the subsidies that we're going to be putting into Obamacare over the next decades. By 2033, as you can see, Medicare is consuming like 69 zillion percentage of our GDP, and we need a way to get that down so that we don't have a budget crisis. So this has led to what I like to call the search for the magic pot of money. During healthcare, we heard a lot about this. Every time, people would say, well, this entitlement's going to be very expensive, how are you going to pay for it? And people would come up with a magic pot of money that was going to allow us to spend more money while getting better quality. This is the holy grail of healthcare. So, first up, we had unnecessary treatment. Many of you may remember when Obama basically accused people of doing unnecessary amputations that did not go over well with surgeons who protested that they usually only amputate limbs if they're gangrenous or otherwise need to come off. But more broadly, this was, and I touched on this last night, but since some of you weren't there, I will go over it again. The favorite example of everyone is back surgery. Because back surgery, you shouldn't get back surgery. It's bad for you. It's much better to get physical therapy in all but very few cases. And so I personally love to trot this example out. And I was giving a talk, and I said, unnecessary back surgery, we'll get rid of it. And this back surgeon came up afterwards, and he said, what are you talking about? I said, there's all these studies. And he said, we've read the studies. You get them to go to physical therapy. So it actually turns out often when you try to implement this stuff in the community, it's a lot harder than when you're doing a great study, you've got a lot of dedicated experts, and the people know that they're being studied. There's something called the Hawthorne effect. It's named after a factory in Chicago where they wanted to study the effect of lighting on workers. Bear with me, this is relevant. And so they decided they raised the lights. Productivity went up. Brighter light. Makes workers work faster. So just to see in another part of the factory, they lowered the lights. Productivity went up. Lowering the lights makes them. Well, what it turns out is that when you study people, they know they're being studied, and they change their behavior in response to that. The most recent example of this in development economics, they were very excited about new methods for, in a developing country, new methods for agriculture. They convinced a bunch of farmers to try it, doubled yields. Very exciting. Then the yields dropped back to zero. Why? It turned out that when they'd promised the farmers, they had this exciting new project, all the farmers took their best field and they put it in there, they took all their best seed and they worked really hard in it, but they would have gotten the same result if they'd stayed on, done exactly the same thing without the intervention. So while there are promising studies in this field, it then turns out that when you do, say, Medicare pilot programs, very few of them pay off in terms of, even at the pilot level, in terms of actually delivering cost savings. So, end-of-life care. Have we all heard about this? We all die too fat. We spend so much money at the end of our life. Totally wasted. Well, it turns out that if you look at this, it's harder than it sounds again. First of all, it's hard to tell when the end of someone's life is. Right? Half of the money, they say half the money comes of the high-cost treatment patients comes at the end of life. Well, the other half didn't die. We don't necessarily know which group is which. Also, it turns out that the way that you do these studies is you grab everyone who died. And then you see how much you spent on them. Well, you spent a lot on some and not so much on the other. Well, it didn't matter. They all died, so clearly we didn't need to spend that money. Well, yeah, you grabbed all the people who died. What about the people who lived? Right? So it turns out to be a lot harder to do this stuff than it initially sounds. When you read the study, you get all excited, and then you dig into it, and you think, oh, right, I can't just test the people who died. I have to look at whether this. Excess cost growth. That's what we've been talking about. We're gonna pay providers less. So we've actually done this, I don't know, 20 or 30 times in the history of Medicare. And funnily enough, as you may have seen from those charts, cost growth hasn't really slowed. Why? Well, okay, so I ratchet down what I pay my doctors. I'm only gonna pay them, for a simple heart attack, I'm only gonna pay them $100. Numbers don't really matter. Well, it doesn't have to be a simple heart attack. Maybe it's a complicated heart attack. Maybe he should look harder for the things that make this a complicated heart attack to get reimbursed at a higher rate. There's various terms for this, upcoding, code farming. But what it boils down to is that this kind of pressure where you just mechanically say we're going to reimburse everyone 3% less next year tends to, it's like those old grabbing things that they give you for physical therapy for your hands, and you squeeze it and it just pops out elsewhere. Also, you have things like now, if there are any doctors in the room, I'm sure you're familiar with the sustainable growth rate. This was a mechanism where we said, if doctor reimbursements grow faster than inflation, we're just going to cut them. That's it. Well, that worked great as long as doctor reimbursements were growing slower than the rate of inflation. The first year, doctors really screamed when they were above the rate of inflation. The second year, they went to their congressman. The third year, there was no sustainable growth rate. They did a temporary fix. We've been doing the temporary fix to the point where now, if we allowed the rate to take effect, we would have to cut doctor reimbursements by almost 40%. This is obviously not a politically sustainable solution, and this is one of the big problems with these kinds of sort of mechanical restraints of growth, is that they tend to be undone by the political system. Comparative effectiveness research. Do head-to-head trials of drugs. We're going to find out which ones, and procedures and everything. We're going to find out which ones work and only use those. Again, a lot less here than meets the eye. Not that we shouldn't do this. We should. We should be doing comparative effectiveness research. But the benefits for cost control are far from proven. It may turn out that the more expensive treatment that people aren't using is more effective. What do you do then? That has happened more than once in these trials. Also, it can be quite expensive to find out who works on what. One example is that Medco is now actually funding its own clinical trials into who more expensive anticoagulants for arterial stents work for. There's a portion of the population they do. Well, there's a lot of concern that it may turn out that it's more expensive to test the people than to just give them the more expensive drug. Wraparound services. You've heard this. We shouldn't put people in nursing home. We should give them all home health care. And as a benefit for people, that's probably true. People do not thrive in nursing homes. They want to be in their home. But there is a problem with this. People really don't want to be in nursing homes, so they will avoid doing the spending. If the choice is go to a nursing home or stay home and kind of struggle along, people will try to choose staying home and maybe having a less than perfect life. If the choice is stay home and struggle or have home nursing services, well, bring in the home nurse. And so while it's actually true that if you compare any given patient cared for at home versus cared for in a nursing home, it's cheaper to care for most of them, not all of them, at home. The problem is that you encourage a whole group of patients that you weren't spending money on before to come into the system. And so it doesn't always end up being cheaper. Pay for health, not for treatment. It's the holy grail, right? This is what we all want to do. We don't want to pay someone to stitch up our legs or stitch up our hearts. We want to pay them to make us healthy. Here's the problem. What is health? How do you measure it? And once you've measured it, you have this problem. So for example, when they started measuring doctors, cardiac doctors, on their outcomes, you publish these board tables that say, this guy has really good outcomes, this guy has terrible outcomes. Well, what do? Don't take sick patients. Sick ones die and they screw up your numbers. So you improve the outcomes, but you improve the outcomes by encouraging people not to take on the sickest, neediest patients. And we complain about this, we've heard a lot about this with insurance companies. It can also be done at the doctor level. You also had a big problem when we tried this several times. You end up having a big problem with the providers going bankrupt. You pay them per head. They get 2 bad cancer patients and they're out of business because they're overhead. So you have to have really huge doctor groups. And then those bring their own issues. Not everyone wants to be treated by a huge doctor practice. Not everyone wants to practice in it. And in some areas, especially rural areas, you'll be familiar with the problem. They aren't, you don't get the scale in a small town that's miles from nowhere in order to have that sort of a practice. So, one by one, our magic pots of money in healthcare reform disappeared. We had some stuff that was supposed to do cost control. We still have IPAB, which is going to basically refuse to compensate for things that we've deemed to be. They're going to change the compensation formulas. The problem is this is both politically vulnerable, and it's really, really hard to decide. You have to set up criteria that are very uncomfortable in terms of saying, well, if it costs more than $50,000 a year to keep you alive, we're just not going to. That's not a discussion that most of us are willing to have, and that leaves these sorts of boards extremely vulnerable. But we do have one magic pot of money left. This is, I'm sure many of you have seen statistics like this before. Percentage of our population that is healthy, It varies by how you calculate, by the study, but this is, one fairly representative study, percentage of the population, about 40%. This is a healthy weight. Overweight, the percentage of the population that is overweight or obese is larger than the population who are at a healthy weight as designated. A healthy weight in most of these studies is a body mass index of under 25, between 18.5 and 25. There's a very small portion of the population that's underweight, but it's basically supermodels and people with cancer, and we don't really have to worry about them in these studies. Most people fall into one of these three groups. So this has been the new magic pot of money. If you look at, it's been growing. And by one estimate, we spend $147 billion a year on added treatment costs for obesity. This was it's got a big splash. It's a study from the CDC. You can see what they did is they looked at Medicaid patients, Medicare patients, and they said how much excess, and private insurance patients, said how much excess are we spending on the overweight patients? And they came up with a figure of $147 billion a year. So this is the magic pot of money. Let me complicate that a little bit. It's been growing over time, dramatically. So if you look at, here we have the prevalence of obesity in various states. It's obviously concentrated in the South for reasons, and in the Midwest for reasons we're not entirely clear. There's big regional disparity. There's also obviously a huge time disparity. In 1990, you do not have any state that is in orange. In 2010, basically we're all in the yellow to orange range. This is what the charts look like over time for obesity. Extreme obesity is designated as a body mass index above 40. And then, as you can see, actually, interestingly, the percentage of the population that's just overweight hasn't really changed much. What's really changed is this line in obesity. That's been very worrying for public health experts. And obviously, it's not just cost. It's quality of life and all of the other things that we associate in health that we associate with obesity. So how can we save money? We end obesity. America's war on obesity is ready to start. We get people to eat less and exercise more, do childhood interventions, redesign our environment to encourage exercise, get out of your cars, people, back onto walkable public transit. We shame them, that's big. I'll be talking a little bit more. We change the kind of food we consume. Look, we found the magic pot of money. Let me complicate that a little bit. Look what's been happening over time as we got more obese. Life expectancy has been going up dramatically. This is, it doesn't seem that dramatic, but and frankly, for me, now that I'm looking 40 in the face, an 8-year life expectancy at the end of my life seems like, hey, I'll take that. Let me complicate it a little bit more. Let's look at America's healthcare cost growth compared to the rest of the OECD between 2004 and 2010. We're over in the low end. Now, some of these countries like Slovakia, they were a communist country, they're getting back on their feet. Yes, their healthcare system probably wasn't very good, but we're lower than folks like the Netherlands and New Zealand. These are folks with big socialized healthcare systems that are doing all the cost control growth. They are much thinner than we are, and their healthcare costs are growing slower. If you look at what happens to America's healthcare spending, we're actually basically in the pack until about 1980. Something interesting happens in 1980. It's a little bit of related financial history, which is that as any of you who are alive then, remember there was a big inflation. During this big inflation, Europe manages to keep a handle on its healthcare cost inflation, and we don't. So in the 70s, we have a big inflation. In the 80s, people have gotten used to huge reimbursement growth every year, and it keeps going. And you can argue about why this is. We have a number of things that we try to do to control healthcare costs. But basically, for 10 years in the 80s, or 5 years in the 80s, it starts going up. It starts leveling off a bit, and then it grows again. But in fact, by now, we are not outside the OECD average. The reason that our healthcare costs are so high is that we were growing from a much higher base. And so even 2.5% a year, to throw out a number, off of 1,000 is bigger than 5% off 100. And that's the problem that we're facing. But we are not facing an issue where, because America is so fat, our healthcare costs are just growing dramatically faster than everyone else's. They're not. So, basic questions. If obesity is so bad, why is life expectancy rising? And not just rising a little bit, rising a lot. Over the same period, basically that 1960 period, we get a little bit fatter in the 20th century, but basically the big period is 1960 to 2000. And yet life expectancy rises dramatically. If obesity is so expensive, why are our costs going slower than countries that have much lower obesity problem than we do? Even more basic questions. Here's some really basic ones. What's causing the obesity epidemic? Do we know how much it's costing? Do we know what the effects are on people? And do we know how to make people thin? These are the questions, though, that rarely get asked when you see these, oh, obesity is driving 20% of our healthcare costs. We're going to get rid of that, and then we'll be able to afford all the other healthcare we want to do. I'm going to argue that these questions are all a lot more complicated than you would think reading the medical media. So just want to start with this is where we are right now. So there's a slight variation in distribution. Men are more likely to be overweight than women by quite a bit. But when you look at the growth, the changes, they're not that dramatic. You have clearly a substantial group of what appears to be mostly upper middle class women keeping themselves thin. So if you look at education, it is very strongly correlated with how educated you are. The drop-off between basically everyone else is up here, and then it drops down when you get a bachelor's or higher than a bachelor's degree worth of education, and especially for women. This is where we've been. So, I mean, you don't have to read all of this data, but you can sort of look and see that, look, in the first study in 1962, these are national studies done by the government. In the first study, you've got the average male who's 20 to 29 years old weighs 169 pounds, and the average male now weighs about 183 pounds. This is a dramatic increase. It's about 20 pounds. So if we were all at the average weight for say a 25 to 34-year-old man, which was the average age in 1960, they would weigh 168 pounds. So let me complicate this a little bit. Age distribution of the United States has changed dramatically. We've gone from a median age of 29.5 in 1960 to a median age of 37.2 now. That is a big shift. And what happens, I'm sure that many of us in this room can sadly attest, what happens when you get older? You get a little chubby, right? Yeah, I used to be thin. So if we had just done nothing but advance the age, this is what we would expect. We would have moved from an average age in the 25 to 34-year-old, the box we saw before, we would have gone up about 7 pounds for the average man just because of age advancing. Now, that is not the whole story. I don't want to suggest that, I mean, we really are getting heavier. And you can see, in fact, that there's this dramatic decline in the 75 and over age range, although that's not really clear because people who are older tend to waste. You know, they have more diseases, they're not moving around as much. And so in that very elderly category, you probably see people who were heavy at 65 and are less heavy now. But nonetheless, there is clearly some trend where age cohorts, that baby boomer age cohort, has a higher rate prevalence of obesity than the people before them. There's also a racial component to it. So we see that blacks and Hispanics, in general, are much more likely to be represented in the overweight and obese categories, and whites are more likely to be represented in the non-Hispanic whites are more likely to be represented in the underweight and healthy weight categories. What's happened to Americans' racial composition has changed dramatically. I don't know if you saw that in the last year, for the first year, we had fewer white babies born than non-white babies. America is changing. We've got a lot of immigration. That is changing our racial mix. And that, to some extent, is probably showing up in our obesity figures. We quit smoking. Great news. But what happens to people who quit smoking? So interestingly, people who never smoked are quite likely to be thin. This is from the Framingham Nurses Study, one of the largest longitudinal studies that's ever been done of health. They followed thousands of nurses for decades of their lives. So what's interesting is that if you've never smoked, you actually were the least likely to gain weight, although, of course, right, what are the never smokers like? A lot of them are marathoning and biking and so forth, and tending to be people who are extremely committed to a healthy lifestyle. But people who've quit smoking a lot of cigarettes gain a huge amount of weight. So it's good news that we quit, but especially for the baby boomers, who were the largest smokers and also the largest quitters. I mean, they were the big, in terms of how many of that generation smoked, it was the baby boomers, and then it started to taper off. And so you can see we've tapered off our smoking, which is great news, but that too is going to lead to a little bit of weight gain. Again, I am not implying in any way that this is the whole story, but this is part of the story. So, the obesity story is a little bit more complicated than everyone just spending all their time at the 7-Eleven, like downing big gulps like Cookie Monster. Second question, do we know how much it costs? And I want to suggest to you that it's actually harder than it sounds. So there's basically two types of studies. One is that you can model it, right? You get these estimates of what individual diseases cost, and then you figure out how prevalent those diseases are, and you can get some incredibly large number that really impresses journalists, and then we blare it on our headlines, and you get your name in the press, and your department chair is really happy. But these are really sensitive to their initial assumptions, and I think they're kind of hard to scale up. Second is the data mining. So we go out and we, as I talked about with that earlier study, the 147 billion study, we go out and we look how much does it cost to care for overweight people versus obese people versus normal, healthy weight people. But this too is really vulnerable to correlation and causation. I mean, to raise one question that I don't personally think we know the answer to, does obesity cause diabetes or does diabetes cause obesity? Right, we know that when people have diabetes, they gain weight after they get diabetes, after it develops. So, there's clearly a metabolic syndrome that is underlying those things, and we can produce improvements by getting people to lose weight, but it's not clear that it's the losing weight versus other dietary changes they're making, doing more exercise, which is usually associated with a weight loss program, but which independently produces health. Exercising is good for you. You should all go out and run 2 miles after this session. The other thing is unobserved variable bias. So often these studies control for your marital status and your income and so forth. What they can't control for is like, are you stressed out because people are mean to you because you're fat? And that sounds funny, but in fact, when a big study, for example, of British civil servants, all in the same healthcare system, all with the same employer, all in the same country, the people who are high-ranked live a lot longer than the people who are in low-ranked jobs. We're very responsive to how our fellow citizens view us. And that can, in fact, have impacts on weight. So in fact, if we say that shame is one of our strategies, we could be producing the bad health outcomes that we're trying to cure by shaming people. But more than that, there's all sorts of, do you get fat because you're sick? This happens. It's somewhat, you try to control for it, but you're never getting all of it. Someone may have gotten heavy because, say, their asthma's acting up. The asthma is going to kill them in 10 years, but they haven't gone to a doctor, so all you know is. These things are really, really difficult to tease out. Big studies are hard. Medical studies are hard. People don't tell their doctors everything. It's hard to describe, what is good health versus poor health versus fair health. You're dealing with the internal universe of a human being and then trying to extract kind of useful statistics from it. It's always going to be difficult. So the next question, do we know what the effects are on people? Let me complicate this story a little more. Here is a recent study that came out in January of 2013, made huge headlines. Why? Because it showed that obese people who are not super obese have lower mortality than healthy weight people. People were shocked. This was not a shocking outcome. They've done this study before. They've done it multiple times. This is what if you look, I brought back in the, green, yellow, red. Look, the green people are dying more than the yellow and the orange people. And again, this was not a shocking outcome. We have seen this outcome before, and every time, people forget it. More than that, the researchers who do this, when they are interviewed in the media, they always say the same thing. Now, I don't want to say that I'm not suggesting that people shouldn't lose weight. But actually, you are suggesting that, but you don't want to say it. There is something in us that really resists the conclusion that being overweight might be healthier. And yet, so my mother's very thin. Her appendix burst last February. She almost died. Why? She didn't have any body fat. So when there were complications, my mother lost 23 pounds in the hospital. She only weighed 115 pounds to start with. So people are actually, when you are older, there actually does seem to be not of extreme obesity, but of mild overweight, there seems to be productive effects because you have more reserves to see you through the inevitable illnesses that beset us as our immune systems weaken. This is what this person has a lower relative health risk, according to that new study, than someone who is a healthy weight. This is a 5'9" woman with a BMI of 33. So I want to go back to this chart, and let's look at this. We have a bit of movement in the extreme obese, and those people, terrible health outcomes. I don't want to minimize this. Being extremely obese, having a BMI of over 40 is very bad for you. But that's not where most of the movement is. Most of the movement is in that obese category. And some of that is arbitrary line drawing, right? We have a category. We have 25, we have 30, we have 35, we have 40. Well, if you go from a BMI of 29.9 to 30.1, you just became obese. If you go from 34.9 to 35.1, you are now extremely obese. Does anyone think that your relative risk mortality jumps up by 30%? No. Some of these things are artifacts of the fact that we have to draw a line somewhere. And as you do, as the population ages, as people get a bit heavier, they move into new categories that seem to implicate their mortality risk and do somewhat along a long continuum, but not in the dramatic way that these necessarily show. We are getting movement into the extremely obese. We are getting movement. I don't want to say that we aren't. But again, it's not where the bulk of the movement is. The big dramatic increase is in that obese category. So if you look at the distribution of weights, right, again, you can see up there at the 95th percentile, we are getting sizable movement. That is bad. But if you're looking at the sort of lower weights, it's not quite as exciting, right? We're seeing mostly movement within BMIs that this new meta-study suggests are basically have a fairly low relative risk. We're only at the 90th percentile are we even moving over just slightly into that higher risk range. So this is, one of the stories that you can tell, right, is that, okay, well, we're not dying, but man, we are sick. We are sick and disabled. Being fat is terrible on your knees. It's bad for your joints. You're in your apartment. You can't move. You're on one of those little scooters, right? So here is expected years of active life expectancy for people at various ages in the United States in 2000 and 2006. It's just a 6-year period, so these are not dramatic movements. It's increasing. If obesity is so terrible for us and we are all getting so fat, why are we getting more active? Now, this is white women, so you might want to say, well, this is fine for white women. They already have pretty low rates of obesity. Let's look at black men. Same thing. 2000, 2006, increasing active life expectancy. Now, you can see America's sad racial disparity in health outcomes, and I don't want to minimize that, but just in terms of obesity, we are not seeing what the headlines would lead you to expect, which is that we're all going to be stuck in our apartments having to have food brought to us by Derek because we will no longer be able to move. So I've argued that the effects on people are more ambiguous than most people would think from reading the media. I'm now going to argue that we don't know how to make people thin. So here are the interventions, right? I'm giving you the greatest hits of my colleagues in the media writing about this. Eat less, exercise more. We do childhood interventions. We redesign our environment. Change what kind of food we consume. Now I'm adding another one, medical interventions, right? Drugs or surgery are basically those two. So eat less, exercise more. This is the standard advice that we're basically browbeating doctors into giving their patients, right? And doctors get quite angry about it. If you talk to people who are really heavy. I talked to one woman who said she had gone in with a sprained ankle, and another who said she'd gone in with conjunctivitis, and both of them were told this wouldn't have happened if you weren't so fat. I don't know how being fat gives you pink eye. I'm somewhat skeptical. They tend to get everything filtered through how fat they are. Well, I can't treat you until you lose some weight. What sort of thing is that for a doctor to say? I can't treat your hypertension until you lose some weight. Hypertension drugs are, in fact, and this is something that overweight people do hear from their doctors. Hypertension drugs are one of the cheapest and most effective interventions that we have. Why on earth would you say that? Even if you think they should lose weight, give them the hypertension drugs now. Don't try to bully them into losing weight by withholding something that could actually lower their risk of stroke. So let's talk about eat less, exercise more. This turns out to be really complicated. Let's look at some studies Again, I'm doing mostly meta studies here because it's easier, which is studies of studies, because they tend to aggregate results. So here is a meta study of what are called hypoenergetic balanced diets and then very low energy diets. Very low energy diets would be a diet of somewhere under 900 calories a day. This is the 5-year weight loss. So in the average very low energy diet, participants will lose between 8 to 10% of their body weight. 5 years later, they have kept off an average of 12 pounds. Now, when you look at that line, I'm going to go back to here. You look at that extremely obese line. Does anyone think that having those people lose 12 pounds is going to change their health status? There is some evidence that dieting can reduce hypertension, diabetes, et cetera, but there's also evidence that when you stop dieting, the effect goes away. So it's not clear whether it's the dieting or the actual being thinner. But the majority of people, the majority of participants, the overwhelming majority of participants in most diet studies regain most or all of the weight within 5 years. Many of them regain much more than they weighed before they started. And now you hear fat acceptance people will say that they're regaining the weight because they dieted. I don't think we know. I don't think that there's good science on whether or not dieting causes you to regain weight. But here is one thing that we have done. We have run the Eat Less, Exercise More controlled experiment on weight loss approximately 1 billion times in this country in the last 20 years. And the results are overwhelmingly in. We do not, with Eat Less, Exercise More, produce significant weight loss capable of sustained health benefits that lasts over the long term. That is a very robust result. And yet, the public health community spends almost all of its energy on some version of Eat Less, Exercise More. Redesigning our environment to encourage exercise. This is very popular where I live in Washington, D.C., where it's already pretty walkable, so we just get rid of the parking and get people out of their cars. So let's look at some of the studies on the effectiveness of exercise instead of calorie control for weight loss. So I couldn't find any that actually showed that exercise produces sustained results for weight loss over a 5-year period. Exercise alone seems to be very ineffective at weight loss. It is very good for you. Like I said, go run 2 miles. But I'll be here when you get back. But seriously, exercise is very good for you. It doesn't make you thin. It's extremely good for you. You should all do it. But here's the thing. Public health experts that I talk to will say this, oh, we know that. We know you need calorie control. We know that getting on the treadmill is good, but if we tell people that, they won't get on the treadmill. I don't think that lying to people about exercise making them thin is actually on net, because what happens when they notice that they've been on the treadmill for 3 months and they're not any thinner? Oh, this must not be working. It is working. It's making your heart healthier. It's going to make you live longer. It's not going to make you any skinnier. We have tied up health in this country with thinness to a bizarre extent. I can't tell you the number of people in Washington, D.C., who are on diets and claim that they're just doing it because they want to be healthy. They live on a perpetual diet, right? But I don't care about being thin. I just want to be healthy, right? If cheeseburgers and Doritos made you thin, they would be eating nothing but, right? 95% of these people, because we take thinness as an example of outward virtue, right? There's this great quote, I think from Anatole France, who says, if the hangover preceded the drinking, then drunkenness would be a virtue. And there is some element of that, right? It is the outward sign of inner grace. I care about myself, unlike fat people. So if you actually look into research on this, it turns out that fat people are not like thin people. They're not just fatter people. They're not just thin people who ate too much. If you actually force feed thin people, they don't get fat. They've done experiments with prisoners where the prisoners were eating 10,000 calories a day and gaining a little bit of weight, they were pudging up a little bit, but very little. And some of the really skinny people didn't gain any weight at all. And conversely, if you take obese people and you starve them, they get thinner. But they're not like thin people. Their metabolisms have dropped dramatically, and they are thinking about nothing but food. Gina Kolata, in her book, Rethinking Thin, which I recommend to all of you, is a great anecdote from a guy who was in a prison camp in World War II. And he says, if you can imagine what had happened, you've got thousands of 18 and 19-year-old boys who are in a prison camp together, and they're not talking about girls at all, they're just swapping recipes. That's what starvation does to you. Your body shuts down your metabolism, and then you can think about nothing but food. And if you think about when you listen to obese people who are talking about their experience, who are struggling to stay thin, what are they saying? I think about food all the time. And I want to think that it's personal virtue, that I'm not obese. But you know what? I don't think about food all the time. I don't have that feeling. Food doesn't make me happy. It just doesn't. Like when I'm sad, I don't get happier if I eat a donut. But many people clearly do. They report an experience I'm not having. But somehow we have turned that not into, I have a different experience of being hungry than someone who is heavier, but they don't care about themselves, and I do. So childhood interventions. This is also like when people kind of reach the point of despair, where they're like, we've run so many PSAs telling people that they shouldn't drink soda. And we've piled like 8 zillion sugar cubes in a dramatic display at City Hall to show people how bad sugar is. And they're still eating sugar, and they're all fat. They say, you know, we got to get to the children. We're gonna change the children. We're gonna go do school lunches and more gym and exercise. We're gonna educate the parents and educate the kids about healthy eating. I'm sure most of you are aware that most of these efforts break down simply because the kids refuse to comply. That the kids bring Cheetos to school when you healthy up their lunch, and eventually you have to stop the program because like half the children have dropped out, including often in big city school districts. You've got half the kids on free lunches, and a lot of them are bringing Cheetos to school instead of. And so a lot of these experiments just have to be terminated. But of the ones that succeeded, let's look at some of the evidence on that. So this is a meta-study from Australia. I love the headline. Childhood obesity interventions focusing on environment pay off, right? A mean difference in adiposity of negative 0.15 kilograms. That is a third of a pound. Let's show a chart so that we can really visualize that, right? In the 0 to 5 group, we did get them to lose as much as half a pound. As they got older and they got more control over what they ate, the numbers dropped down to basically, now does anyone think that if you look at those, we go back to those statistics, that losing a 20th of a pound, sorry, like a fifth of a pound rather, 20% of a pound, is going to produce these and these are the successful ones. These are the ones when you went out and did this is when you did the meta-study, paying off. There is a great disconnect often between our talk on obesity and the actual results that we seem capable of getting. So shame, this is from a man named Callahan at the Hastings Center, who has been urging that apparently the big problem with America is that fat people aren't aware that they're disgusting. And if we would just communicate that more effectively, then they would stop being fat. I'm exaggerating a little bit. He's a very well-meaning man. He cares a lot about obesity. But the idea that we have not communicated our grotesque hatred of fat people is just silly, right? Look at shows like The Biggest Loser. You take people, and they're all wearing, right, like really tight spandex. Why? So that we can better gape at how fat they are. Look at reality shows and the way that they dress people. You look at shows, I've done it too, but I did it for a reason. I did this to point this out. When you do a story on obesity, what do you see? Oh my God, their fat is oozing out of their pants. It's disgusting, right? This is how we treat fat people now. They are very ashamed. They are very depressed. We tell them all the time that they are repulsive. Women, especially, have much worse employment outcomes. They have worse dating outcomes. We have not communicated that we don't like fat people. We've been sending that message loud and clear. And it has not changed. Or maybe it has. Maybe we would be even heavier. However, here's the interesting thing. We've actually leveled off. So the big increase was between 1960 and 2000. Now we're more like a little creep. So medical intervention, I'm just going to discuss this briefly because, as a pharmaceutical researcher that I talked to said, look, nature really wants you to get enough to eat. That's like priority, that and reproducing are priority number 1 and 2. So what you don't want in any animal is a pathway, is a neural pathway that can get knocked out really easily, right? You think about it as an engineering thing, you don't want only one button that says eat. if that is the most important thing that the organism has to do. We have redundancy after redundancy after redundancy. We have like 90 different hormone systems which tell us that we're hungry and we should go get some food. Knocking those systems out have proven on the pharmaceutical side, very difficult, and the pills that we have tried have had extremely bad side effects. If you look at the ones that were pulled off the market, like fen-phen, and you look at the ones that are still on, which basically give you diarrhea if you eat too much fat. That's a drug that we sell. Then we have things like lap band surgery. Now that's very successful at making you thin, but what are we now seeing in the follow-ups? The mortality results aren't so hot, which just goes back to, this is a great unexplored territory. We aren't sure about the effects. We aren't sure about how all these pathways work together. It's really difficult to tease out correlation and causation, and to think that it's the fat rather than some underlying process that produces both fat and unhealth are really difficult. In some cases, obviously, we understand that if you're very heavy, it's bad for your joints. And that if you're very, very heavy, if you're morbidly obese, that it's hard for your heart to pump that much blood. But at lower levels, it's really, really difficult to tease out these kinds of subtle effects. So I don't find this a satisfying answer. We're not going to give everyone gastric bypass surgery, nor should we. So the last one that everyone loves, of course, is we're going to change what kind of food we consume, right? America's war on big gulps. I grew up in Manhattan, so of course this is a special spot in my heart. And I actually kind of buy what is called now the hypercompatibility thesis, or as I like to call it, the Cheeto conjecture, which is basically this. There are combinations of food. If you look at rats are thin in the lab, right? And then they get fat because when you feed them on standard American diets. And the kind of story about this is we just eat too much fat and sugar, but there's actually an emerging alternate thesis, which is that rat chow is really boring. And if you had nothing to eat but vitamin fortified oatmeal, you wouldn't eat very much either. You would eat when you got really hungry, and then you would stop, which is basically what rats do. But if you give rats food that tastes good, like us, they want to eat it. Why? Let's go back to the organism with all of those feedback mechanisms. What is taste good telling you? I've got a big fat animal here. It's just dripping with fat, and it's delicious. I've got ripe fruit that's full of sugar. I found a salt lick in an area where I want to load up. It's telling you that what in nature is a rare supply of food is available, and you should eat as much of it as possible. And food scientists, I don't know if any of you read the article in the New York Times Magazine. It was great. Highly recommend it to all of you. Food scientists are busy maximizing this in all of the food we eat. Cheetos are basically like the perfect food because they dissolve on your tongue and you don't feel full. But they deliver just this maximum amount of flavor. You don't want to deliver too much flavor because then people get sick of it. You don't want to deliver too little because then it's like oatmeal and they don't want to eat it. But now we've gotten to the point where we can maximize this. And what happens? We eat a lot more Cheetos. The fundamental problem with modern food is that it tastes good. Now, here's the problem. How do you stop people from making food that tastes good? Can you imagine? So here's our first answer. We tax it. Some problems with this, though. So the estimated price elasticity of soda is pretty low. This is a term that economists use for, when the price of something goes up, in general, I want to buy less of it. But there are some things that's more true of than others. The price of gold jewelry has doubled, and as a consequence, I buy zero gold jewelry now. On the other hand, the price of food has also doubled, and I still buy pretty much as much food as I did before. Why? Because I gotta eat. So the difference between those two, food is a relatively inelastic good, and jewelry is a very relatively high elasticity good, at least in modern America. So when we look at sugary food, how easy is it by increasing the price to get people to substitute away? So by one estimate, a 20% tax would cause an average weight loss of 0.6 pounds. And when we go back to that chart on morbid obesity, think about where you have to get that sweet spot in order to produce a really substantial weight loss, the kind that we think for that very obese population is going to push down their weight. Well, the problem is that's pretty regressive, right? Warren Buffett is not sitting in his house, nor is Michael Bloomberg, worried about what happens when the price of sugar, octoquintuples. But people who live on, making $25,000 a year and maybe like to make cookies for their kids once a week, for them, that's a huge deal. So what you end up doing with the problem, one of the big problems with these taxes is that in order to get a result, you have to push up the taxes so high that you are hurting non-obese people at the bottom of the income distribution. And if you look back at that chart on education, it is true that people are more likely to be heavy if they're poor. But in fact, there are still a lot of thin, poor people who don't seem to be unhealthy. And we would be hurting those people. So regulate it, right? We just tie their hands with red tape so they can't get to the sugar. It's in front of them, but they can't move. But let's talk about this. Let's think about what's implied by regulating making good tasting food. Right? Don't do that. Are you going to have a good tasting inspector who's going to go in and be like, no, this tastes too good, get rid of it? Nope, too much, especially, so you've got a multiplicity of problems here. The first is that obviously big corporations are going to be by far in the best position to meet this. So you've got this big engine of growth at the bottom, and not just growth, autonomy and entrepreneurship. Many people, I'm sure many people in this room, dream of owning their own restaurant or bakery or some other business. Well, if you now have to comply with these regulations, it's really easy for McDonald's to do calorie label requirements. It's really hard for small businesses to. So you can do what New York did, and you exempt the people with fewer than 5 outlets, was New York. Okay, but then you walk into these restaurants, and you go into a good restaurant in New York, or even a cheap, fun family place in New York, and they are piling on the pasta, and you're getting 3,000 calories on a plate. So this is really difficult. If you actually imagine the interventions that would be required to maintain a not quite so good tasting American food network, or alternatively, because this is what a lot of the hyperpalatability people say, is cook your food at home. Cooking food at home, my grandmother might have packed on a few pounds after she got married, but they had dessert twice a day, and most people who cook all of their meals from home without prepared foods tend to be thin because it's a huge pain in the tuchus to get, you think to yourself, I'd really like to have a snack. Well, I don't really want to go out and cook something, so maybe I'll just wait until dinner. And so snacking is actually one of the biggest, most dramatic portions of calorie increase over the last 50 years, is that people just eat between meals constantly. Why? Because it's really cheap and easy. It's really interesting to go back, actually, and read Utz's describing its own struggles with marketing its potato chips in the 60s. What was the biggest barrier to adoption? Housewives perceived them as expensive. Can you imagine a housewife being like, no, honey, I'm sorry. That dollar bag of Ruffles, it's just not in the budget this month. Maybe next month. But that was actually something that people really thought about back then. They prepared most of their food from scratch because it was much more affordable that way. Part of it is advances in packaging and technology, advances in transport, all sorts of things. But what it boils down to is that the food then junk food was more expensive than making it at home, and that's why people ate less of it. The other question we have to answer is, by what right? How do we assume the right to go in and start telling people that they're not allowed to have sugar? Last night, again, for those of you who missed it, I said, HIV is really expensive. Most people in this room would not say that we should have a government program to discourage people from being homosexual on the grounds that they might catch AIDS and that would be dangerous, even though it's going to cost us a lot of money. But they're costing us a lot of money is, in fact, generally the rationale, right? The primary rationale for this. It's so expensive. $147 billion. We've just got to stop them. But there's also a sort of paternalist impulse, right? They don't really want to eat those Cheetos. There's this kind of higher self, which is not, somehow has been shut off. And if they knew what I knew, they would not want that bag of Cheetos if they understood that it was making them obese. Now, this is absurd. Poor people are not stupid. They're aware that Cheetos make you fat, to the extent that we think that they do. Anyway, they're aware of what is on the list of stuff in America that makes you fat. They don't want to eat the food they don't want to eat salads. They're not doing, food deserts were a very popular explanation for all this. And then when we went back and actually measured, first of all, what are people eating? And how far are they from sources of fresh vegetables and so forth? It turned out that there was no correlation. And then, in fact, picking out food deserts was kind of drawing a target around neighborhoods full of poor people. And being poor is indeed correlated with obesity. But we didn't know that they were causally correlated. And I think that the new data, and it's always in a flux, right? Someone could come by tomorrow and be like, no, I've proved that food deserts. But right now, I think the state of the knowledge says food deserts do not actually seem to be a big cause of obesity. And then this is honestly what a lot of this comes down to, right? If it were 60 years ago when we were faced with the same set of choices, we would be arguing for leaving sugar alone and making PSAs warning people about the dangers of homosexuality. Because the elites 60 years ago thought that homosexual men were weak and there was something wrong with them. They had a psychological problem, and that's why they were doing that. Now we know that there is a genetic component and so forth, but we have also changed our ideas about sexual liberty. And we no longer think it is appropriate to warn people against a perfectly legitimate sexual preference. But we've decided that it's perfectly legitimate to warn people against the dangers of eating Cheeto, and indeed to go much farther. Why? Because we've moralized this decision. And I want to go back to this graph for a minute, and I want to point something out. So if we look at this group of people, the bachelor's degree and graduate degree, this corresponds pretty highly to a group that we might call the experts, right? This is all of us. Very few of us are fat. Very few of us are even overweight. And we think that people who are eating Cheetos, because they're not like us, there must be something wrong with them. They must be making a bad decision, and we need to intervene to help them to make. So this is what we might call the treatment group. It's everyone else. And last night I talked about the ways in which these conversations about individuals versus communities often morph into communities against other communities. It's communities saying, well, my values are the right values, and I'd better figure out how to make you live by these correct values. And I think that there is a great deal of that in obesity. And that is what you see when you see a public health expert defending a legitimate meta-study that has been done more than once and gotten the same result by saying, now, I don't want you to think that people shouldn't lose weight. Right? Well, what else do your results say? It's safer to be overweight than to be healthy. The last thing we have to think about is what are the costs of this, right? We've been talking as if the costs of doing all these obesity interventions is actually lower than the cost of treating the obesity. And $147 billion is a big number, but it's actually not that big compared to the US economy. It's about 1% of the US economy. And if you think about all the other things we would have to do to the US economy, there's the direct financial costs of doing this kind of intervention, of any of these interventions. There's the public, the shaming, the public stigma, everything from PSAs to radically reconfiguring all of our roads and schools and spending twice as much on school lunches and so forth. And maybe these are things that we should do. But if you are going to sell your obesity prevention efforts as we are going to save money on medical costs, you need to weigh those costs against the costs of the healthcare intervention. It might end up being cheaper to do that than to have a vast inspection mechanism that goes into every food processing company in the country once a week to check whether their Cheetos are too tasty. The non-financial costs. First of all, my priors are, in general, I'm skeptical of government regulation, although not for the reasons that sort of you may think. The government can do anything, almost, but it can't do everything. Every task we assign the government increases the complexity of the government, and that is bad. Regardless of whether you're a big government liberal or a small or a free market conservative, complexity is bad. Complexity makes it hard to start a business. I talked to a small business owner in New York who gave up his business. He was a really liberal professor before he gave up his business, and he said, I couldn't tell whether I was in compliance with the payroll laws. It was not possible for me to know. So I hired this specialist firm, and periodically there's like another $100 for this or $20 for that, and I don't know. I have no way to check them. And he just said, it wasn't just payroll, it was everything. The regulations get to the point of complexity where it's not possible for a small business to know whether they're in compliance. And that means that you shouldn't just weigh a kind of straight cost benefit of any regulation. You should say, look, there's only so many things that we can do really well as a society. Is this worth degrading the other stuff? Is this worth making the other stuff harder? Because it's not just complexity for businesses, it's also true for governments. Increasingly, the story in Washington, people are making regulations that conflict with some other agency's regulation. And then a business owner has to choose, and indeed, the agencies don't even know this. and they have to fight it out in court. But there's also the cost to the people. People like Cheetos. Maybe you don't like Cheetos. I personally think they're tasty and delicious. But regardless of where you come down on that, taking something from people that they like is a cost. It's not a benefit. Forcing you to move somewhere in the kind of city you don't like, forcing you to eat food that you don't prefer, it may be a necessary cost. During World War II, we had rationing. Now, we can argue about whether that was actually necessary and so forth, but like, assume it was necessary and that it was beneficial. Okay, we're fighting, the forces of evil. Yes, we should have rationing. We're going to take sugar away from you so that we can put more energy into the troops. That is a legitimate public purpose. But it always has to be weighed against the cost. Most of the costs of obesity are borne not by society, but by the individual. And so you need a pretty high hurdle before you start jumping in and saying, I'm taking that from you, or I'm making it functionally taking it from you by making it cost 4 times as much, or making it really difficult to get, or forcing you to pour your soda into 4 cups. Those are costs. And the problem is that we have very great difficulty, I think, assigning costs that we don't personally feel to other people, to viewing those as costs. Well, you're just giving up Cheetos, who cares? Well, if you really like Cheetos, if someone said to you, you had to give up being a university professor, like 95% of the population would be like, who cares? You sit in a room all day and like talk and read. That's really boring. There's better jobs out there. You'll be fine. You wouldn't feel that way. It's not important to them. It's important to you. And so you always, always have to weigh. Maybe this isn't important to me. It's important to someone else. So I need to be real certain that this is really important before I start going in and assigning myself the right. And then there's the political costs. You've seen this with Bloomberg, right? The reason that the Big Gulp ban got struck down ultimately is that he didn't put it to the city council. He had it run through the health department. He just gave the health department, made a fiat order. Well, why did he do that? Because even in New York, and let me tell you, people in New York are crazy. I've been to city council meetings. Even in New York, that was going to be a real hard sell. It's regressive, right? It disproportionately affects poor non-white people and doesn't affect white people. It is a pain, and it smacks of this kind of paternalism that is really deeply offensive to almost everyone. When someone else is being paternalistic on you, you get really upset, right? The number of laws that I've ever heard someone say, I need you to pass this law because I can't control myself. Just take away my Cheetos, please, right? It's always the other guy. There's huge political costs to this. They're very hard to pass. And again, even if you're a big government liberal, right, you have to say, is this the hill I want to die on? Is this something that I'm actually willing to go to the mat for and sacrifice other legislative priorities, because you always are. Would this be the thing I would pick? So are these costs lower than the cost of obesity? I think it's hard to know. But what we do know is that the overweight disproportionately bear the cost of obesity. It's very costly for them. And so the idea that somehow by raising the cost greatly, we're going to lower this seems unlikely. Sort of economic literature, usually when you have these sorts of problems that are very amenable to easy government intervention, it's because I'm a polluting factory, and the cost to me of dumping stuff in the water is 0, and the cost to someone else is really high. Whereas the cost of fixing it to me is really high, and the benefits are almost 0, right? This is not the case with obesity. The cost of fixing it is high, but both the costs and the benefits are primarily borne by the individual who is trying to lose weight, in part because we've decided to shame them, I might add. Those costs, so it's unlikely to me that you've got a big market failure where the government can kind of swoop in and just say, oh, well, we've got the price of sugar wrong, and if we fix it, everything's going to be okay again. So in conclusion, I think we just lost another magic pot of money. All of this stuff is hard. I don't mean to say that there are certainly a weight problem in this country. I think it is somewhat smaller than has been portrayed in the media. I think it is far less amenable to intervention has been portrayed in the media. And I think that the implications of the way that my primarily white and liberal and upper middle class colleagues talk about how we're going to fix obesity really needs a rethink, because it profoundly often sounds like, well, why don't, I was in communist China a couple of years ago, and we had communist minders on this trip I was on. And in the middle of it, they started, one night, we've been drinking a little bit, and they said, well, you don't understand. The people here, they don't want democracy. They want someone to lead them. They want us to tell them what to do. And I hear a lot of these very paternalistic things, and there's an echo of that in my mind. That the people out there, they don't understand what they're doing, and they need us to come in and guide them because they're too stupid to run their own lives. And I think that, I look around at my colleagues, I'm going to be honest, it's not like I see like all of these incredibly happy, wonderful people who have fabulous marriages and are like super healthy and they're doing everything right. And I would say I want to turn my life over to them. In general, this stuff is hard. Everyone's doing the best they can. And I think that we should stop looking for magic pots of money in places where we really shouldn't go. And I'll leave it there.
Well, thank you, Megan. It's always great to have the sort of standard orthodoxy and challenged, and promotes a good conversation, which is what I'm anticipating we'll have here. So,
I'm sure.
Thank you for that. I'd like to just begin by asking each of our respondents to respond to the points that you thought were most worthy of responding to in this for a few minutes, and then Megan responds, and we'll just have a conversation. So.
Who do you want first?
Yeah, go ahead.
I can't do it. I have to stand up. I'm sorry. It's just the way I am. From now on, I'll talk seated. But it's such an interesting topic, isn't it? Obesity, because it's about health, it's about beauty, and as you said, it's about vice and virtue, and all that mixed in. And I want to start with a complete agreement. We're always looking, just as you say, for a magic pot of money. And for Newt Gingrich, it was fraud and abuse. And for other people, it's drinking and smoking. Cut off drinking and smoking, and we'll save tons of money. And for others, it's let's get rid of obesity somehow. And I think there's lots of things to say about obesity. But if you're looking for forget the magic pot of money. It probably doesn't exist. And every politician first goes to, we can solve the healthcare problem with the magic pot of money. And it doesn't work. Our healthcare costs are high because we charge more for health services. That's the difference between the United States and other countries. But so that's the first thing to say, complete agreement. I want to stop for a second and ask why this is political, because that lies under an awful lot of what you said, Megan. And it's interesting that it should be political. I mean, is there anything more private? And this is a lot of the theme that we've just heard. Is there anything more private than what you eat? When this issue first started coming up, this issue of food as politics, there was outrage. One of the great reformers, Kelly Brownell of Yale University, if you're into this field at all, you've probably heard of Kelly, he says he'd keep coming back from his office, and the right-wing talk radio guys would be calling him all the time, and he'd have these long things on his voicemail. And they say, this is Joe Bob from the radio station, and you're not going to take our hamburgers away. We're going to clutch onto our hamburgers, and you're going to have to come and grab them from our dead fingers, sort of doing a variation on all those other things. And I used to think, what is going to make this political? And then Megan got into what it is that makes it political. It's the question of virtue. We're a Puritan nation. We're founded by Puritans. And this has a left version and a right version, and that's what's made it political. And then I'll get to the paternalism, and then I'll shut up. Mencken's line, a Puritan is someone who's really worried that someone, somewhere, somehow is having fun. For conservatives, the personal is political when it's bad behavior. And in the United States, we've made drinking bad behavior. We've made the wrong kind of sex bad behavior. We've made drugs bad behavior. We're really very intolerant from social conservatives for the kind of behavior other people do. Now, I know I'm in Montana. You guys are a lot looser about this stuff. But among social conservatives, among what you might call the neo-Puritans, it's the individual who is the sinner and has to be controlled. We didn't start this with obesity. There's a long history of trying to control deeply personal behavior, like who gets to drink. Now, I'm a liberal, right? It can be easy for me to make fun of social conservatives. I wrote a book on Puritans, on sin, and I was trying to think of a preface. How do I start this book? And as I was looking around for a story, I went to a upscale food market, equivalent of a Whole Foods. And in it, there was one non-white person, a short, wiry African-American man who had very clearly been plastering all day. He was covered with plaster dust. And if you've ever plastered, it is really hard work. And he went into a coughing fit. He was really coughing. And a woman, very well dressed, strode up to him, put her finger right in his face, and said, "I hope you don't smoke." And I thought it was an assault. And a group of people got around her, and I thought they were going to stop her. And no, they were encouraging her. "I hope you don't smoke." And I thought, there's the liberal version of calling out the sinner, right? The guy was plastering, but it was okay if you were calling out the sin. And it got me thinking, what's the liberal version of what the social conservatives do? And it's this, I think. It's those dastardly corporations that lead us to sin. It's not the smoker, it's the tobacco company. It's not the obese person, it's Ronald McDonald and his really tasty food, just as you were saying. So that, on both the right and the left, somehow took this deeply personal activity and turned it into a sin. Well, now we get to the heart of Megan's case. Is that a good or a bad thing? And there's lots of different kinds of interventions you can make. I'm all with her when it comes, so let's just stick with New York City and take two versions. Should we ban the big gulp? I'm with Jon Stewart on that. Come on. What's that going to do? That kind of political scientists and philosophers talk all the time, right, about paternalism. What kind of paternalism is justified? When are you justified in telling other people what to do if you know better? Sometimes it is. If you've got a 3-year-old and you're not paternalistic, or a dog, you've got to draw certain lines, and if you don't, there's going to be trouble. But I like a sort of soft kind of paternalism, which people call the nudge. That is, I'd like information that will help me make my decisions. Stick to New York City. Another thing Bloomberg did was he required Starbucks and every restaurant to put the calories. Got to post the calories. I love that. You go in, you know what? You go to Starbucks. You know that big, delicious chocolate brownie? It's actually lower in calories than that innocuous-looking Rice Krispie thing. Now, that's useful paternalism. Now, I might eat the Rice Krispies, but I want to know. And you can, if government says to every business, tell them about the calories, and then the person can decide, that's good paternalism. I'm all for that. I don't want to be the puppy being told, don't do this, do that, but I want the information. So I think we can have a much more nuanced conversation about helping people like me stay thin. And that gets us to the other heart of Megan's talk. Does it matter? Is obesity really a public health problem? And here I want to issue a caution. Don't become data nihilists. There are a lot of studies. Some of them are terrible. Some of them are really good. We've got very clear standards of what makes a good study and what doesn't. So the problem is when studies hit politics, it's like, what hitting the fan. Studies don't do well in politics, but they do well in science. We know lots of stuff. But here comes the hard part. Is obesity going to make you sick and going to make you die? And there are some studies that suggest, and I think you touched on this, it's not good for you to be obese. But how bad is it? Or to put it more directly, there's a great debate about whether our obsession with body type, having to do with old views of beauty, they're only about 100 years old, versus the public health ill effects of being overweight. Where do we draw the line? Which is worse for you? And the studies there, you're right, they're ambiguous. So I just come finally back down to what I know. I know what makes me feel good, and I know what my grandmother told me. She told me exercise. She said eat healthy, and she said be sensible. And in the end of the day, that we all ought to do. Exercise, eat healthy, be sensible. My grandmother was right. Thank you.
Heather.
Okay. So, Megan, your question of how do we make people lose weight, I think perhaps the more interesting question might be how do we help people reach their goals? We can debate all day about the cost and what, and I really couldn't tell you much broader the cost on the whole healthcare system and whether it's right or whether it's wrong. But I work with people every single day who are trying to make changes to be healthier, and it really, behind closed doors working one-on-one with folks, I hear continually, I just want to be able to get on the floor and play with my grandkids and get back up. Right? I just want to be able to walk a block without losing my breath. I just want to be able to do these things. And it really doesn't, we can categorize based on BMI and whatnot. And I think you're right, it's really blurry right around the edges of each category. And I could talk all day long about diabetes and that correlation. But really, people just want to feel good about themselves. The first thing that we see is our body when we look in the mirror. But people just want to feel good about themselves and the choices that they're making. And if, we talk about individual choice and, we have the information on a menu, or when we walk into McDonald's or wherever we go, we can make those choices. But to some degree, our choices are already being made for us. Our choices are being made in the system that's set up, and obesity just happens to be the thing that we see. So we're seeing, just with the Farm Bill, that's just one example of, corn subsidies and that feeding into a system that's broken. And you mentioned the junk food, that piece from the New York Times. They know just how to get us hooked so that we can't say no. Right? And that kind of ties back into the corn subsidies. But then we have lobbyists. And the dairy industry right now is lobbying to be able to put artificial sweeteners in milk, in flavored milk, and not label it. So where does our individual choice lie? We try to make the best choices for ourselves and for our families and for our community, but if it's transparent, how do we make those choices once we're able to make choices for ourselves? Another example of that is genetically modified foods that's not labeled. So we don't know what we're putting into our bodies. That might not be on everybody's target area, but it's real. And so those are some policy things that are in place. Just got a couple more points. Fast food chains in the middle of low population, high density areas. Where is the choice? The choices are being made for us by companies that come in and say, this is what you want. What's McDonald's? You deserve a break today. Go have a milkshake or a Big Mac or whatever. So what I'm hearing from people behind closed doors is, I need help. How do I make sense of the information that's out there? How do I make choices that's right for me and my family to be the healthiest that I can be? I don't know if the public health message around obesity is necessarily let's make people thin. I don't think it's about that. It's about getting people healthy. When weight loss is concerned, and I run an evidence-based diabetes prevention program, it's a national program, we talk about 5 to 7% of weight loss that can drastically change your healthcare costs and your health and your quality of life. A little bit of exercise, half an hour a day, right? But what gets people motivated to actually start that process and then continue it on for the rest of their life? Those are the big challenges that I see every day. And, you know, we can talk about the science, we can talk about everything that's out there, but at the end of the day, we all kind of know better on some level. And so what are we willing to do to make it better for ourselves? And what are we willing to do to make it better for our community? You know, Megan, I think you said last night our rules are created by our culture. And so what rules do we want for ourselves? You know, we can't disassociate from different populations as a matter of convenience. We're all in this together. So how do we make choices for ourselves that influence our community? And so what are you willing to do for yourself to make better choices? And what are you willing to do for the sake of your community to make better choices? We need to make the healthy choice the easy choice. It's really at the heart of it. That's what motivates people. Something's easy and affordable.
Megan, first, do you want to make a response to either of these?
Yeah, so I would start by saying that, you know, I oppose agricultural lobbying. But here's the thing, is I think that that's often like this very convenient target. Libertarians love it. It's all ag subsidies. But, you know, you look at other countries, they got the same problem. So it isn't just the American agricultural industry that's doing this. It's not even just McDonald's. There's no correlation, for example, between, so it turns out again, like there's a correlation between obesity and fast food outlets. When you actually look at how people's choices, if you drill down into their choices, you don't see that like the fast food outlet is driving them to do something. What you see is the fast food outlet is there because that is a market where people consume a lot of fast food. And so part of it is that, you know, yes, the choices are shaped by what's there, but it's also that like companies go to where things, and if you look at, say, the Asian markets, where I am, you have Asian markets and bodegas, and then you have kind of convenience stores that are run by Americans, and the Asian markets are just like overflowing with fresh fruit and vegetables in very poor areas, and the other markets aren't, and it isn't because the Ethiopians running the market across the street from me are bad people who don't like fresh food. It's because they don't sell in my neighborhood. Or they don't sell fast enough for that to be a profitable way to operate a market. And so it's complicated to determine which way the choice is running. I will say about the nudges, I'm in favor of transparency. We should all have transparency. You know what happened after the calorie labeling? They did studies on it. Zero effect except for the one study that showed calorie consumption went up. And so, in fact, there's a lot of, you know, things like 401k nudges are also a big thing that we all love. And then it turns out that 401ks don't increase savings. When you look at kind of national comparison data, it doesn't seem to change one way or the other because people can make what bond traders call a synthetic neutral position where I've got a big 401k balance, so hey, run up the MasterCard. Take out a 401k loan. It's actually really, really difficult to nudge people. And I think that a lot of those results, which looked really promising when they have been implemented at the policy level, have not come out. Transparency, in fact, there's now experimental data showing that transparency can actually make things worse. And there's an actual argument that, for example, I had thought that McDonald's, because I'm an upper middle class girl, I grew up on the Upper West Side, where like, you know, as one of my friends said, I think I want to eat healthy, but maybe I've just trained myself so that all I want is a carrot and hummus. Mm-hmm. You know, I think this is what I like, but I don't, it's hard to know, right? There's huge social pressure on girls that I grew up with. I still drink like 12 cans of Diet Coke a day, which is probably not good for me. But like, yeah, we're all eating carrots and Diet Coke. So, you know, these things like, I had thought that a McDonald's meal had a lot more calories than it turned out to. So now I eat it more often.
Yeah, see, on nudges, if someone says, I now have the information, I want to make that choice, I think we'll all agree that's fine. The NYU study is very interesting on New York and nudges. So they put the calories, and in poor neighborhoods, a lot of people thought, I'm getting more for the money. So they'd actually go for the higher calories. And it turns out you need an anchoring effect. So they then tried an experiment where they said an average adult male needs 2,000, big sign, 2,000 calories a day. And I'm spending 800 on one Rice Krispies treat. And that really changed effects quite dramatically.
But
this is
for
all
upper
back
middle class people.
No, it had in Newark as well. In Newark as well at the NYU study. So if you have an anchoring effect, it actually had the effect up and down the income scale. But I don't care. If someone has the information and they say, you know, Paula Poundstone has a hysterical routine on this. You know, I want my Twinkies. if she's got the information, God bless her, let her have them.
But here's my thing, is that when the nudges don't work, what's the next thing, right? Bloomberg's nudges didn't work, and so now we're going to ban big gulps. Now we're going to, and this is, I think the real issue is that we can all agree on nudges, and I'm fine with, I like transparency, I love transparency, more transparency. There's issues with it, because of course it then makes it very hard for small businesses to expand, which is a big thing that we're seeing in New York, is chains are having a really hard time getting a foothold. Like, if you want to open a chain of pizza places, you can have one or you can have 20, but it's really hard to go in between that, because figuring out how many calories are in your pizza is really difficult, and it turns out the calculations also aren't that accurate, but that's kind of a sort of side question. If you want to do artisanal handmade food, calorie counts are impossible. What can you do calorie counts on? Standard processed food. That is where there's the least variation in the ingredients. And so it's really complicated, right? Starbucks has no trouble with this. But me making beautiful homemade sandwiches with whole wheat bread, really difficult. That I make lovingly by hand from my own wheat that I mill, there's no way to tell how many calories are in that. And that is something that we get really focused on. It's just a nudge, it's transparent, it's great. We forget that it costs money and that we're making someone else pay it, and that may in fact have, completely unintended results.
And that's a really good point, and that's an important point about policy, that all policies are interactive. There's no policy ever that you say, here's the policy, that's it, we can go home. You make the policy, you have some unintended consequences, you've got to adjust and you've got to keep adjusting.
But what a libertarian would say is that you don't, right? What are the odds that the calorie counts ever get repealed on the grounds that it's really hard for artisanal sandwich makers to open their chains? 0 in New York City.
In New York City, are you kidding? I mean, the levels of food and the levels of artisanal food in New York City are unbelievable.
No,
but let's just clarify our disagreement instead of just going back and forth. So one argument is don't try at all. Another argument, which involves no government, another argument says good government really can make a difference. I want that calorie count, but I want it in a way that's sensitive and that involves multiple give and play between producers and government officials. And it's going to require nimble government action. And I believe that's possible. If you don't think it's possible, you go with her. If you think it's possible, you're with me.
Let me propose a third way. I mean, I think you look at the government and how many regulations get repealed. I mean, I don't think that it's easy to argue that at any level right now government is nimble. But go beyond that, I actually think there is a third way, right? How come we did the law first and then the study? How come we didn't try the study first and then the law? Why don't we do more randomized controlled studies of policies that we're proposing and roll them out in some restaurants, roll them out in test areas, see what happens? We don't do that, right? We get a great idea. We've read 3 studies. It sounds fantastic. You can, what happens is that you get a policy entrepreneur in the academy. He's got a great, in this case, it's Dick Thaler, who I love, brilliant economist, behavioral economist. A policy entrepreneur in the academy. He gets the ear of some guy at a think tank. That think tank works with legislative aides. Well, by the time the legislative aide has got it, all of the nuance is gone, right? He's got an hour to sit down with you. By the time the legislator gets it, he's gotten 5 minutes. And so, all of the nuance about the studies, well, there was this one where it didn't work, but then there were some problems with the controls, and we don't think it was that all gets stripped away, and it never gets undone. I really think it's hard to argue that the government goes back and fine-tunes these regulations and really does a good job. It doesn't.
In this case, we did have studies. So we went to Newark, and we went to Newark, which gives you a real, very different population, and we tried a series of different ways of doing calorie counting. That's why we know that poor populations respond to anchoring effects. The 2,000 calories is all an adult male needs in a day. So that it's not so that we simply blanket the effect without doing all kinds of interesting studies. And it's sort of useful to have a New York. It's kind of nice to have a Bloomberg. It's not like the whole country is getting blanketed. Let's see how it works in New York. None of us live there. And let's see how it works. And then other people can take the experiment. Here, you in Montana. I suggest you do the calorie counts. I think you'll be happier for it. But hey, it's your decision.
I love the debate that we've got going on here, and I appreciate the way you sort of crystallized the point. I wanted to give Heather just, unfortunately, because we're out of time, perhaps another 60, a very brief additional comment to close us out.
I guess I would just close in saying, I hear a lot of comments on research and the, what we're not learning from it, and I think that's a disservice to everybody who does research and looks at it and try and implements these interventions. And what are we learning from it? And how can we continue this discussion, right? Because to just close the door on it and say, forget it, it's not worth it, we give up on each other. And I don't think that's where we need to be.
Well stated.
Yeah.
Okay.
Good
Well,
ending.
I'd love to continue, but I want to thank Megan and thank our panelists for this wonderful discussion, and invite everybody to, after the break, come back for the afternoon sessions. And what's that? Yeah, that's right.
We're going to run.
Running
Yeah.
2 miles
We're
and then,
starting a run, a fun run, while you're eating.
In my heels.
right, and the lunch of your choice. So thank you very much.